Good morning. Thanks for coming today. It's kind of reminds me of school. Everybody who's in the back of the room here is, I guess early in the morning you just want to do your own thing and wake up. But hopefully you'll be woken up by Dr. Lichtman, our first speaker. I just wanted to. My name is John Carroll. I'm with Plexus Communications. We worked in collaboration with SIOG and with the University of Nebraska, who is the accrediting body for this program, and also Moffitt. I just have to say thank you so much to Dr. Balducci, Dr. Exterman, for helping us with this and hosting us for this event. SIOG has been trying to get an event like this in the United States for some years now. So this is our first step, and we appreciate everybody that's in attendance. What I wanted to do is to just go through a couple housekeeping notes just so that we can get started. For this program is accredited for 72.5 contact hours. And so for nurses, you'll get a certificate of completion that you can then turn into along with the agenda to the state accrediting body. And for pharmacists, for the evaluation form, all you need to do, because this was accredited for pharmacists after the evaluation forms were put together, so you'll need to just put your NABP CPE profile number. I see folks shaking their head, so just put that in the bottom with your birth date and on the evaluation. And Brenda Ram, who is the representative from the University of Nebraska, the accreditor, she's out there. She'll hand out the evaluation forms, so if you could just complete those evaluation forms, and she'll then share with you your certificate that you can then turn into the state if you're a nurse. So, but we also have an ARS system today, so audience response questions. There's just for CME purposes, and we have some knowledge-based questions at the front of the presentation that Dr. Lichtman will go through, and at the end of the entire presentation. Very easy to use. You've all used it before. Just click it when prompted for the ARS, and just please make sure to not take these with you or stick it in your pocket. Just leave them with us at the end. Other than that, I think that we should be all set to go. I think I covered everything that we need to, but like I said, we appreciate, again, Moffitt for taking the time and supporting us on this program. So I'd like to introduce the first speaker today, Dr. Stuart Lichtman from Memorial Sloan Kettering Cancer Center, and he is the president-elect of SIOG.
Well, welcome. As John said, this was a long time coming. It's a geriatrics meeting, so I won't talk about gestation, but gestating for about 5 years. So first of all, thank you for coming. As it says, the first meeting, I hope the first of many meetings. I wanted to particularly thank, again, the people from Moffitt, Lodovico, and Martine, who were instrumental in organizing the meeting. Plexus, the speakers, who were very generous of their time. I truly appreciate it very much. Many thanks. I want to urge you to join SIOG. There are benefits for people in all aspects of healthcare, nursing, pharmacy, medical oncology, surgery, radiation therapy. So again, thank you very much, and we will move on. Okay. First, I want to talk a little bit about SIOG. That's why we're here. Essentially, is a SIOG event, and why is that important? Why is that a significant thing? SIOG is as it says, multidisciplinary society, including people in all fields of oncology, geriatrics, and allied health professionals, and again, allied health professionals, nursing, and pharmacy, and even physical and occupational therapy. It's actually, SIOG's been around 15 years. We've had annual meetings every year except 1 year. We've had annual meetings, very well attended meetings, I'm happy to say. We've had 300-400 people come to the meetings. So it's a good place for interaction, networking, Again, we have over 1,000 members, and I'll also show you more than 40 countries. And again, to emphasize the nursing and allied health interest groups. And also, we've just developed in the last year or so this Young SIOG interest group, which has been very good and to get people excited about the field of geriatric oncology and give them inroads. And again, it's a networking opportunity, and also to be on the SIOG board and to help develop programs and other things. Now, to talk about our mission, I think we all know that the population is aging, and cancer, as the population ages, the number of patients with cancer is going to increase. And obviously, the major risk factor, as we all know, for cancer is aging. And the world is aging, as I'll show some data later. And it's going to be an epidemiologic challenge, a financial challenge, a social challenge, how we're going to be able to take care of patients, because also who's aging are the health professionals who are taking care of the older people. We're all aging. And there's actually a work shortage in oncology, certainly in geriatrics. So one of the goals of SIOG, one of the major goals, is to foster the development of health professionals in the field of geriatric oncology and help optimize treatment and develop guidelines, algorithms, treatment plans, support for the patients, and education for the physicians. So again, as we all know, the population is aging thanks to improvement in healthcare, comorbidities. You know, it used to be cardiac disease was the major cause of death, but now cancer is really the major cause of death, as the control of cardiovascular disease in developing countries has been diminished. Most cancer deaths are in patients over the age of 70, and as we know that the geriatric oncology patient is unique, I call it the ultimate in personalized medicine. That's geriatric oncology. Because of the heterogeneity of the patient population, we're not treating 20-year-olds with Hodgkin's disease. We're treating older people with not just their cancer, their comorbidity, their social issues. The expression financial toxicity has come into vogue for good reason, and that's been a major problem in taking care of patients. Medical oncologists and all oncologists who take care of older patients are going to have to learn some geriatric principles. We may have to do it, they may be kicking and screaming to avoid it, but the reality of the situation is, whether they like it or not, they're going to kind of have to learn it. And I think it puts us in a good place to help develop these programs, people who are dedicated to the field and who have analyzed and have generated the data that future clinicians are going to use to take care of older patients. And I think SIOG can be instrumental in that development. Well, it is instrumental, I should say. The world is aging, even in developed countries, certainly it is. I mean, the U.S., right now in Western Europe, is really aging fastest. If you look at, I don't have it up here, median age. For instance, the median age in Japan and Italy right now is approximately 45. That's the median age. And if you go to Africa, it's obviously much younger. It's actually in the teens. But as these median ages rise, particularly in Western Europe, the healthcare burden has shifted. The number of people who are actually working in these societies is actually diminishing rapidly. And who's going to pay for all this? Who's going to take care of patients? But people have termed this in the past the silver tsunami, and I guess we're kind of in that tidal wave now. We're all getting wet from the tsunami, and I think a lot of people in this room have recognized it for the last 20 years, and I think the world out there, even in the New York Times this week, there was an article about aging. Is really focused on Europe and how aging is going to affect the aging of the population is going to affect all aspects of society. So SIOG has three major directions, strategic directions that it focuses on: education, clinical practice, and research. So in terms of education, obviously the annual meeting is the premier event. It brings people together, networking, presentations, posters, educational sessions. When the first few SIOG meetings started, it was really just kind of people getting together, giving educational talks, and kind of saying, gee, this is a good idea, maybe we should do this. And what's it evolved in is a meeting kind of like an ASCO kind of meeting where there actually is a lot of data presented, where new ideas and new thoughts are coming up. And again, it's more than just an educational session. It's really a scientific meeting. And it's very interesting to see how that's evolved. And hopefully we could do that at these kind of meetings in the U.S. Oh, I should mention, just to mention again. And I'll mention again, I mentioned the JGO, the Journal of Geriatric Oncology. We have educational books. And it's interesting, in Italy, where the Italian population is aging the most, it's kind of interesting, Dr. Manfredini is organizing a course, SIOG Treviso Advanced Course in Geriatric Oncology. In clinical practice, there's one of the major projects of SIOG is guidelines, and there's multiple task forces which people can become involved with, whether you're a physician, a nurse, pharmacy, whatever. And these task forces have published in very respected journal, the JCO, Annals of Oncology, etc., guidelines and position papers and consensus statements about treating of older patients. And it's a good way for people to become involved in SIOG. Relatively painless. And then research, again, along the lines of geriatric oncology practice, grants. I remember that SIOG Young Investigators Group. So from the research area, SIOG per se doesn't do research, but I think we could be a tremendous educational support for people who are doing research, the tools, the advice, all sorts of things we could provide, and a forum like the Journal to publish their research. And which is extremely important. To mention the journal again, Dr. Hurry is the editor-in-chief. Dr. Mohili in the back is the co-editor. It launched 5 years ago. It's now publishing 6 issues a year. It used to be 4. It's relatively new, but in two years or so, it was already indexed in PubMed, which I thought was a great achievement for the journal. And Dr. Hurry, I think a lot of hard work, as you know, goes into this kind of thing. The impact factor is slowly rising, so keep referencing yourself and your friends, and, we could get that going. That always helps. That doesn't hurt. The number of submissions has increased. It was like the rejection rate. So, but it just shows you that people are being critical and making good suggestions, but the quality of the what's being published over the years, over the last 2-3 years, I think has risen, and it's really demonstrated by these articles are being referenced, not just by your friends. So I think it's very important. And it's interesting to see when people are publishing guidelines, independent of SIOG, I've seen references from JGO publications. We've had an impact in all areas of oncology. Our members take care of a lot of patients, and hopefully by doing that and influencing their colleagues, they could expand the area, and at least the recognition that geriatric oncology is important because most of the patients treated are over 65, obviously. The meeting has really expanded, as I mentioned before, and we have upwards of around 400 attendees from many countries of the world. And we also, the other educational forum we have a national representatives group of SIOG. So each country has someone who's targeted to lead the effort of geriatric oncology in that country for SIOG. SIOG governance, we have people from all countries, many from the U.S. Obviously, we're having this forum today. We've had other meetings in other parts of the world other than the main meeting. I mentioned the Treviso course. There's a new article that comes out every month in the ASCO Post talking about geriatric oncology. We've had 2 already. I had the first one on talking about SIOG, and we just had one from Dr. Holland from Sloan Kettering, who does psycho-oncology, about the psychological care of older patients with cancer. So you should keep an eye on that article. And again, we've collaborated with other institutions, obviously Moffitt, Dr. Hurry is from the City of Hope, Sloan Kettering, and I'll talk about these other organizations later on. So in conclusion, thanks again for coming. Thanks for your support of SIOG. Hopefully there'll be other meetings, and if you could come to our annual meeting, usually it's in Europe, fortunately. This year it's in Prague, but I think it's an extremely important event. So I'm going to move on. Yeah,
before you move
sure.
On, I've been told by the Praxis people that if you want to become a member or renew your membership, the front desk people, if you want to become a member or renew your membership, the front desk people can do it for you. and you just need to give them your credit card. We are way cheaper than ASCO.
Yeah, that's for sure. All right. Thanks, Martine. That's important. That's why we're here. That's part of the reason we're here. Okay. Oh, so I'm going to do these questions. They're kind of softballs, but just to help you play with the buttons. So I'm going to go these through quickly because I don't want to, we have to stay on time. So the first question is, what's the life expectancy of a 75-year-old woman in good health based on an article Martine wrote years ago? Okay. All right. What's the median age of death of colorectal cancer based on the current SEER database? I will tell you, I've asked this question at the Vail Clinical Trials Workshop where the premier fellows in the U.S. are, and 3/4 get this one wrong. So there is an education gap, even for the top fellows. Ah, interesting. What is not one of the activities of daily living? I should say using the cell phone, using the smartphone. If you're in Manhattan, it's figuring out how to use the Metro card. That is a challenge also. How to put money on your Metro card. That's a major challenge.
We don't have that one in
It's a challenge. I was in the subway the other day, and I said, oh, my God, I don't know what to do. Okay. Cancer is a disease associated with aging, and the number of older adults with cancer is on the rise. What % of cancer deaths occur in people over the age of 65? A couple of softballs again. Okay. CLL is a disease of the elderly. The median age of diagnosis is? Distribution here. And the last one, prostate cancer is the most common malignancy among elderly men. Despite initial response rates of 80-90%, nearly all men develop progressive disease following androgen deprivation therapy. Fortunately, in the last 5 years, more tolerable treatment options and better suited for elderly patients have been approved, which is not a new treatment for castrate-resistant prostate cancer. So, okay, so we'll go back to that at the end of the meeting, and we'll get the right answers. Okay, so I'm going to do the first talk. It's about what's going on in the U.S. and the world in geriatric oncology, basically. Just to give some perspective what people are doing, not just going to meetings, but kind of in the trenches. Well, first of all, I always like to say all oncologists are geriatric oncologists. I usually say whether they know it or not. But that's obviously because of the aging of the population. I mean, we have our weekly patient conference, and people present their new cases, and obviously about 2/3 are over 70. It seems like 2/3 are over 70. I kind of work in a suburban population, and patients that I see who are patients of Memorial Sloan Kettering, if you know the geography of New York City, the thought of traveling into New York City from Long Island, you have to cross a bridge, is an emotional thing that people just don't want to deal with. So the older people tend not to go into Manhattan. And I looked at our own patients with gynecologic cancer that I treat, our GYN patients, and there's a clear age shift in who gets treated in the city and who gets treated in the suburbs. And it kind of also what that does is it affects the issues like clinical trials and things like that. So it's a social thing, But there is a shift of a few years, like 3 to 5 years. We're treating older patients. We're on Long Island, and the network, as it's called at Memorial, versus the people in the main campus, and those are the people you read about who go on the studies. So we do put people on studies, but it's a different population. Okay, so there are a number of organizations involved in geriatric oncology: ASCO, CARG, the cooperative groups, and some cancer centers. Obviously, ASCO has been at the forefront of geriatric oncology actually for many years. B.J. Kennedy recognized geriatric oncology as an important issue, and he's really recognized for that, not just geriatric oncology, really medical oncology. In 1988, he, at his presidential address was devoted to aging and cancer. And here we are, it's 27 years later. Some of his suggestions are just now being kind of thought about, but he really recognized this epidemiologic shift that was coming, and it's reflected in his article. And it's interesting to read in terms of the history of oncology, what he said then, which is still true today. 3 years later, he wrote an editorial in the JCO talking about clinical trials for older patients. And again, if you read this, it's sort of like, there's, nothing, what comes around goes around. It's like the same thing. And he talks about patients over the age of 70, which is probably the more important issue, not just the age of 65, plus clinical trial design. I should say that if you go back even to 1983, there was a meeting at NCI talking about doing clinical trials in older patients. And if you read that 1983 document, you thought it was like written yesterday. So we still need to move forward. Now, obviously, ASCO's recognized the importance of geriatric oncology, like I had mentioned. At the annual meeting, there is a geriatric oncology track, which is actually changing a bit this year, hopefully for the better. They're going to incorporate geriatric oncology talks and ask speakers to focus on older patients as part of their presentations and not just have an independent track, though there is a clinical science symposium. So anyone going to ASCO, the clinical science symposium is usually an excellent forum for this kind of thing. Geriatric oncology is part of the educational committee. The program committee, interestingly, does not have a geriatric oncology area. It's part of patient and survivor care. So if you're ever on that group, which I have been, you kind of have to be the advocate for geriatric oncology presentations. I mentioned the clinical science symposium. We do have a special interest group, which I'll mention, who's working on a number of projects for ASCO. The Vail Clinical Trials Workshop has focused on special populations, of which geriatric oncology is one of them. So that's a program where the fellows come, top fellows come and try to learn how to develop clinical trials. So we could have an influence there, which I think is very valuable too. And ASCO itself has guidelines, and one of the projects going on right now is trying to urge the people who do ASCO guidelines to make sure that they include geriatric principles somewhere in the ASCO guidelines. So that's a work in progress. They have the B.J. Kennedy Awards. Some people here have won that award, and it's a recognition of the field of geriatric oncology, and I think it also provides a forum for people to discuss geriatric oncology principles. I think even more importantly, though, is these ASCO publications, because that's really what oncologists see. I always feel one of the greatest ways to move geriatric oncology forward is through ASCO publications, primarily the JCO, but I think these other ones are extremely helpful. On the left is this ASCO Connection, which comes out in January, though I have absolutely no idea how many people read this. For all I know, no one reads it. I don't know. But actually, that's Dr. Huria on the cover of at City of Hope doing her geriatric oncology thing. So that came out in January. It was a nice, very long article, very detailed, a lot of good information. I'd mentioned the ASCO Post, which will have a geriatric oncology article once a month. And I think this is a way to make awareness. Now, very interesting, more recently, about a year or so ago, the Institute of Medicine had a publication delivering high-quality cancer care, charting a new course for a system in crisis. A lot of this was devoted to treating cancer in older patients. It's interesting, the Institute of Medicine report, which talks about increasing the breadth of data on older patients, ensuring they're represented on studies, and increasing the depth of data, a lot of jargon, gobbledygook talk. But it's very interesting. If you go back literally to B.J. Kennedy, 1983, I could show you this. It looks exactly the same. Interesting, IOM doesn't take steps to implement policy. They just make suggestions. So because of that, ASCO formed a working group, this ASCO Older Adults and Research Working Group, and kind of make a response to the IOM report and to say what's important, what's not, how we should move it forward, et cetera, et cetera. So that's a very, very valuable thing that ASCO is doing for the older patients. So what ASCO has talked about preliminarily is improving the evidence base for treating older patients with cancer, looking at clinical trial design, geriatric assessment, looking at the biology of aging, issues about research design and funding. And one of the things that people have been talking about for years and years and years is, drug companies, pharma typically doesn't study drugs in older patients for whatever reason, fear, they don't conform to clinical trials, but, that's always been the case. But some incentivization for pharma in some way to promote research in older patients, maybe after a drug has already been approved to do another study looking at various degrees of frailty or what we could decide, and to see appropriate dosing and scheduling of drugs in older patients. Because as we all know, the clinical trial dose or design is one thing, treating patients who have a million problems and other issues is a much different thing. We need to recruit patients on older trials, and I have an issue with clinical trial reporting that the papers that are published really don't adequately discuss the older patients. ASCO and their Cancer Care of America last year published, and one of the things I wanted to highlight, as I mentioned earlier, this demand for oncologists is growing, not just geriatric oncologists in general, but however, the workforce is going to grow by a lesser amount, aging of the population, and as I said, the aging of oncologists, because if you look at the median age of oncologists, it's actually rising, and there's a lot of early retirements for various reasons, electronic medical records just being one of them, if ever. I mean, I was doing chemo orders at 11 o'clock last night, so that's just the way it is, but it's a burden, and there actually is a wave of retirement, and there's very few geriatricians, and if there are fewer medical oncologists, we'll have a problem. I've mentioned a few times the Cancer and Aging Research Group. This was founded at the City of Hope by Dr. Huria, and it has really evolved, I have to tell you, an extraordinarily active and very valuable research organization. I'll mention one of their seminal study, which is extremely important, but its goal was, and it's really achieving this goal, I will say, organized to give junior attendings and researchers an opportunity, extremely strong leadership. They have conference calls constantly. I just hear voices on the phone. It's weird to meet people. You just hear their voice. But it's really been a training group for young investigators, and it's already made a very, very significant contributions, a lot of publications, and a very valuable things. One of their most important thing is that's being incorporated in clinical trials is this predicting chemotherapy toxicity based on 500 consecutive patients from multiple institutions, and looking at predictors of this is hematologic not hematologic and non-hematologic toxicity based on kind of simple parameters. And I think if medical oncologists and people seeing patients say, "Oh, I don't have time, I can't do it," most of these things you could probably do in a few minutes. So I think we have to kind of change the mindset. But what the bottom line of all this was, was that when they asked clinicians to predict toxicity, they really couldn't predict it much at all. But at least based on this first pass of this study, there seemed to be based on the various risk factors, there seemed to be ability to predict toxicity. Now, this really has to be validated in different patient populations, which is being done. This was kind of a mix of people, various regimens, all over the place. They may have had chemo before, they may not have had chemo before. What was interesting, though, even people, what I find is very interesting, even in the low-risk group, there was a 27% incidence of significant toxicity. So even patients you think are okay, that are doing fine, who even by the scores have a low risk, 25% is high for a low risk. And it just shows you the vulnerability of some of these older patients. Now, the cooperative groups, there's been this merger, and people have to come up with new acronyms. It's been a big project, an acronym project from the NCI. But the CLGB and North Central, and actually one of the surgical groups, have merged and called the Alliance for Clinical Trials in Oncology. Thought that was cute. The CLGB, which has really been at the forefront, has actually had a cancer in the elderly community for actually 20 years now. And I think they've made a great impact, not just in publications, but just inside the cooperative group itself. There's been important trials. Among probably one of the most important was the breast adjuvant trial that Dr. Musk did. They've analyzed databases, and interesting, when the NCCT joined, actually I think in a sense it created a stronger group, because particularly the Mayo Clinic group has been extremely active in this. They're clinicians and they're statisticians, so it's actually been I think a positive thing. So they've analyzed databases, the data mining, we're going data mining crazy with that, educational messages, and consultants to other committees. Now, there's a new group called NRG Oncology. There's a company that makes things for the sun. You get electricity from the sun, also called NRG. I see their commercials on TV like every day. I always get confused. Anyway, so this is the RTOG plus the GOG, and they made an NRG. So the group, when I go to the meetings, I was used to dealing with cervical cancer and endometrial cancer, and suddenly talking about head and neck cancer. So I thought there was a different cervical cancer, I guess. I don't know. Anyway, so probably the most successful study, and one of the more successful studies in geriatric oncology, which hasn't been published yet, but really will be published soon, is GOG 273, which was a prospective trial of treating older women with ovarian cancer and using the CARG risk factor as part of the study. So this will be one of the ways the CARG will or will not be validated in a prospective manner. We don't know. I mean, we'll see the validity of that instrument in a uniform patient population. This has been very good, because one of the successes of this study was that it's not randomized. It looks randomized. It's not randomized. It's physician-patient choice about regimens and whether in ovarian cancer is a big issue about giving surgery versus chemotherapy up front. That's a controversial issue. And this way, patient-physician choice, and I think that helped accrual tremendously. So it's not randomized. It allows neoadjuvant chemotherapy, which for older people actually may be better. We don't know that for sure, but when you see an older woman with a huge amount of ovarian cancer, she's really not ready for an operation, and giving chemotherapy up front may actually be better. But that remains to be seen. We really don't know that for sure. And there's PK, and there's a lot of stuff going on in this study. And the regimen 3, which is just completed, had accrued these are not the exact numbers, but accrued 100 patients in 3 months. I mean, it was unbelievable. The surgeons and the medical oncology people who do this kind of work were very enthusiastic about this study. Now, hopefully that'll be an incentive for more studies, though we proposed a phase 1 study that the NCI nixed, so who knows. The other thing that the GOG and other people are looking at is surgery. I mean, a lot of us are medical oncologists, we're not surgeons. All of us, though, see patients who've had surgery, particularly what I do. Every patient I see has surgery as doing medical gynecologic oncology. So a number of issues about surgery. In ovarian cancer, at least, the median age is 64. Older patients have been known to have higher mortality in ovarian cancer. Their survival is less for not clear reason, whether it's under treatment, biology, who knows what. Older patients are more subject to toxicity, particularly neuropathy, longer post-op recovery, shorter survival. And a lot of patients, particularly who get surgery up front, actually never get chemotherapy, which is a problem in general in these situations. The patient doesn't even get chemotherapy. They don't really recover from surgery, and that's why neoadjuvant may be better. But anyway, so geriatric principles have been applied to surgical patients. This was a number of years ago. Ricardo Ordicio talked about the PACE, which has been used in a number of studies. I'm just going to mention it. At Sloan Kettering, we have our own surgical assessment. All patients over 75 get a pre-surgical geriatric assessment. One of the studies that have actually been published is predictors of post-op delirium, which is important obviously in the immediate post-op period. And the predictors, as you might expect, are age, dependence in IADLs, and comorbidity. So it really became a simple thing, but trying to make an intervention now to help post-op delirium. Other studies have looked at falls, how if you look at post-op complications related to the number of falls that patients had in 6 months prior, certainly not a difficult thing to obtain by history. Interestingly, the surgeons love this kind of thing because they don't have to do it, first of all, so they love it. Someone does it for them, but they're trying to make interventions to minimize post-op complications. And a simple thing like the time get up and go has shown correlates with post-operative complications and prolonged post-operative stay. So geriatric oncology is not just medical oncology, it's also surgical oncology. The GOG, because of this, is going to have a study in women with ovarian and endometrial cancer, talking about whether these pre-op assessments can predict complications, and again, undergoing a similar procedure, a very uniform group of patients who have known to have increased risk of post-operative complications and increased mortality. So I'm just won't go into the eligibility, but again, this is going to be one of these physician choice kind of things, and the surgeons in the GOG or NRG now are very supportive of this kind of effort. So it's not just medicine, it's the surgery also. I mentioned SIOG, and I'll just to go back to this briefly, is SIOG has had a number of task forces on geriatric assessment. Again, geriatric assessment, detection of unidentified problems, try to predict. Remember, geriatric assessment was more of a triage thing. We're using it now to try to predict things and hopefully make an intervention to improve outcomes somehow. I think that's kind of the next phase of research. There have been 2 recent publications from SIOG. I had mentioned earlier how SIOG is publishing in pretty high-impact journals, the JCO and Annals of Oncology, the consensus on geriatric assessment and screening tools for multidisciplinary health problems. And this was published within the last year. Actually, the bottom one was just published recently. Number of tools have been shown to be predictive. Some of them associated with chemotherapy-related toxicity. Timed up and go, as I mentioned, was predictive of postoperative morbidity, which is, again, a very simple thing to do. And last year also was published, not specifically from SIOG, though some of the authors were SIOG members, performance of 2 geriatric screening tools in older patients with cancer, again in the JCO, looking at simple screening tools, the FRST screening tool, the G8, which has become a more common and validated screening tool. And in this particular publication, at least, showed that these were predictive of survival. So, I mean, I think some of these principles are going to, what we have to do is how to incorporate some of the things we've already learned into practice. At Memorial, I had mentioned we have a program in geriatric medicine. We have a division of geriatric medicine. Obviously, it's a cancer hospital, so this is all they do, who have worked with the surgeons in medical oncology to develop these programs. They have a geriatric consultation service. They do the preoperative assessment that I mentioned and studies of postoperative complications, a very, very huge nursing education component. I mean, literally every nurse at Memorial now is trained in evaluating, caring for geriatric patients. So as you can see, a lot is going on in the world in geriatric oncology. Multiple groups are undertaking evaluations. I think what we have to do is bring it all together and figure out ways of at least simply incorporating into clinical practice. Karnofsky is very easy. Oh, there are 70, there are 60. Or ECOG, there are 2, there are 3. It takes, takes 2 seconds. It does help. And I think we have to kind of move in that direction so clinicians who are very busy will be able to incorporate practice and these things into practice and use them to help make decisions whether to give adjuvant treatment, whether not to, surgery, all the things that palliative care, all the things we have to do on a daily basis to maximize patient benefit, increase quality of life, and minimize toxicity. So thanks very much.